through HRT and gender-affirming care with empathy and excellence. We're also joined today by a trans individual sharing their lived experience because medicine isn't just about case studies, it's about people. And listening to their stories is how we learn to treat better. We have a quick but very important note. Any form of transphobia, spoken, typed, or implied, will not be tolerated. Anyone making such comments will immediately be debarred from this session and all other future SIMSOG events. No warnings, no debates. And if you're vibing with this event and want in on more such events, please consider joining SIMSOG. SIMSOG, the Society of Indian Medical Students of Obstetrics and Gynecology, is the first all-India ObGyn student society. We are extremely passionate about women's health. Membership is free and gives you access to more such events, workshops, and opportunities. Thank you again for showing up, listening, and learning. Dr. Pramila, over to you.
Ma'am, could you please unmute yourself?
Unmute yourself.
Yeah, so I'm just trying to share my screen. 1 second. So I go to the window, right?
Yes, ma'am.
Window, right?
Yes.
Share the window, right? So the window should show up. Share the window. 1 second.
And also, I would like to take permission from everyone here to record this meeting, if that's okay.
1 second. 1 second, just I'll do one thing. I've done one thing. I've shared the presentation with one of you, like to that mail ID, Academic Team. You can share from your end.
Sure, sure. We'll do that.
I have shared to the thing. Like you can just see it has come to your mail. Just share from your end. This window is not opening. I don't know what's happening. Am I audible? Am I audible? Yeah.
Yes.
Yes,
Yes.
Got the presentation? Just share from your end.
Yes, ma'am. Hold on a minute. We're on it.
So good evening, everyone. And today, as I understood that you all of you are either interested in obs and gynae or would be working with different fields concerning gender incongruence, and you want to have some idea about how we go about treatment or how we go about the management of gender incongruence. So today I'll be just giving you an overview about gender incongruence. I'll tell you that what are the guidelines, how we start the hormone therapy, and what are the different things we monitor when the patient is on hormone therapy. And I'll also be talking about a little bit about what are the things we need to follow and what are the other important things which we need to see for. Also, it's important that when you talk about gender incongruence, we have to understand that it is no more considered any disease or mental illness. That's very important. And we don't need to actually get the psychiatrist reference for making the diagnosis. But why we get a psychiatrist letter is to rule out any other psychiatric illnesses which may get exacerbated because of any other psychiatric illness which can get exacerbated because of the hormones. And also if the hormones can cause any set of problems or side effects. So that is why the gender incongruence patients, we send them to psychiatrists for that reason, not that they need to make a confirmation of the diagnosis. So can we go ahead? Now the slides are showing up. Yeah. So can we just go ahead with this next slide? Yeah. So, so now we have different terminologies which we use. Something is coming on the screen. Once again, is everybody able to see the screen clearly? Some thing is not black thing is not coming on the screen. Okay, fine. So we use different terminologies when we talk about gender incongruence. We say that it's just a societal term that we classify people as male and female, but we need to have 2-3 things in mind before we go and discuss about it. Like one is the gender. The screen is gone. Yeah, correct. So it's coming now. It's coming now. So one is the gender identity, and then we have the gender identification of what like the person identify themselves at and what they express themselves at. And then we have the gender assigned at birth, and then we say that they're physically attracted to or emotionally attracted to. So there are different terminologies when we talk about the gender unicorn. Can we go ahead? Yeah. So now when we talk about the gender identity, we know that this is an internal, deeply held sense of gender. Like for transgender, we say that their gender identity actually does not match with their sex, which is assigned to them at birth. So most people either have a gender identity of a man or a woman or a boy or a girl, but they like some of them may not fit into any of those two choices and they may just want to remain fluid. But the thing is that gender identity is not visible to others, but gender expression is. So let us go down to the next. So we used to previously call this as gender identity disorder. And this was the previous version which we used to say, and the ICD-10 when we used to say gender identity disorder. But now we don't label it as a disorder anymore as per the ICD-11, which says that the gender incongruence is basically a term where we say that when the gender identity or the gender expression actually differs from what is typically associated with the design gender, the designated gender. So if the patient is being designated by birth as suppose a male and a patient is a phenotypic male and the patient is not identifying herself as a male and the patient identifies herself as a female. So we say that it's a trans female and the patient identifies as a female. Similarly, patient who is designated male at birth has been phenotypically male and has a male karyotype but is not comfortable with the gender and wants to identify with the other gender. So that we say that, okay, trans female. But if the female is born and the patient does not identify herself as a female and they want to convert to the opposite gender, that is trans male, so that we call it as trans male. So this incongruence is that the patient is not comfortable with the gender which is assigned at birth. It is incongruent to the patient's identity and the patient wants to be of the opposite gender. So a male may not like to be a male, may want to be a female, then we call it trans female. A female may not like to be a female, may want to be a male, then we call it as trans male. We also know that all patients with gender incongruence will not have gender dysphoria. That is also very important. So it's not that everybody will be dysphoric. Dysphoric means distress. So all the individuals who have gender incongruence will not be dysphoric. So it's not necessary that everybody will have dysphoria. So some of them may come with dysphoria and they may be very dysphoric, but some of them may not be so much. So then we talk to the next slide, please, the gender reassignment. When we refer to the procedure which is done, whether it is surgical procedure or some of the cosmetic surgery, so-called we call, which makes the person live the gender which they want to live as. So suppose a male is not comfortable with the male gender and they want to be like a female. So they would like to go for breast implants, they may like to go for orchidectomy, or similarly, if a female is not comfortable with the female gender and would like to get her mastectomy done or uterus removed or ovaries removed and would like to convert to a trans male. So this is how the gender reassignment is done. Can we go to the next slide, please? Can we go down to the next? Yeah. So that is what we call as a gender reassignment surgery. Now, when we talk about gender roles, this is the, can we go? Gender roles means when we have the behavior, attitude, and personality traits that a society in a given culture designates. Like some people say, this is a masculine behavior, this is a feminine behavior. This is how the society associates. This is not like we can assign it for all, but this is how our society is. So they have typical things like males will do this, females will do typically this. So these are societal terms, gender role, what role they play in the society. Can we go to the next, please? So how do we approach such cases? Can we go to the next slide, please? So we are actually coming out with the Indian guidelines. We have the Indian guidelines in place. I am also part of those guidelines. So where we have, we stay at here. So we have Indian guidelines also where we say that how to diagnose or how to start the treatment for a gender incongruence trans males as well as trans females. But we have the criteria. So whenever we classify somebody having gender incongruence or dysphoria because of that, we know that there has to be a marked incongruence between the one's experienced or the expressed gender and the natal gender for at least 6 months duration, which should be manifested by at least two of the following. So one is a marked incongruence between the one's experienced gender and the primary and secondary sex characteristics, or the strong desire to be of the opposite gender. So, and to have the sex characteristics of the opposite gender, and also if there is a strong desire to be like the opposite gender, to be treated like the opposite gender, and a conviction that the one has typical feelings and reactions of the other gender. So out of these, like we know that at least two have to be there for at least 6 months. But by the time actually we see patients with gender incongruence, it's not even 6 months, it's much longer. Because we have patients coming to us at the age of 25, 22 plus. Now I have lots of my patients who are coming to me at 18 or 19 years of age. But so because we can't start the gender-affirming hormone therapy before the age of 18 in India. So they come to us after the age of 18. But if you talk about my practice 15 years back, we used to get most of the patients above the age of 25, 28. But now a lot of patients are becoming aware and they're coming to us. A lot of individuals are coming to us at the age of 18 or 19 when they are ready to sign the consent and they know that what they are doing is right and they can take decision. But also it is very, very important that we need to be very sure that we are making a right diagnosis. And that is why we take the help of the psychiatrist. Though we say that it is not a psychiatric disorder, yes, we agree, it is not a psychiatric disorder, but the psychiatrist help is taken only for the reason that we want to just check or we want to just see that the patient does not have any other thing which can mimic gender incongruence, any other personality disorder or any other thing, or they have some psychiatric issues which can be exacerbated by the treatment with the hormones. So that is the reason we take a psychiatry letter. The psychiatrist confirms that the patient is fit to start the gender-affirming hormone therapy and there is no contraindication to start the gender-affirming hormone therapy. The patient is not having any other psychiatric disorder which can mimic gender incongruence, neither they have any personality disorder. Can we go to the next, please? So next slide. So this is now how we say ICD-11, that is, they have added trans-related categories. They have removed from the chapter on mental and behavioral disorders. So now we have a de-psychopathologized disorder. Like we don't say it is a disorder anymore. We say that it is just a condition of a sexual health, and we need to just see that it is like normally a patient comes to us or somebody comes to us for their management of their problems. Similarly, we have to do that. So it's not like a psychiatrist has to confirm the diagnosis, but as I already told you, we take a psychiatry reference for ruling out other psychiatric disorders, not to confirm the diagnosis. Can we go to the next slide, please? So this is our idea group consensus, which we have come up with. This is on the medical management of adult gender incongruence individuals who are seeking gender reaffirmation as females. So I'm also so this is what, sorry, there was some issue. So this is the consensus statement which we took out, which is published in IGM. It is freely available. This is an idea group consensus statement or medical management, which we have talked about in the individuals who are seeking gender reaffirmation as female. So in this, we have put forth the guidelines where we have told that how to approach it, what are the treatment options available, what are the guidelines, what should we follow up, and how should we go about it. So can we go to the next, please? So it is available freely online. You can get it. This is for the males. So this is the idea group consensus statement on medical management of adult gender incongruence individuals who are seeking gender affirmation as males. So this is for the males. In this also, we have clearly told that how to go about it, how do we make a diagnosis, how do we decide on the further management and how do we follow up these patients. But also we have to, like, I'm also part of the IPATH and in the academic council, and now we are coming up with the guidelines and with the statements in different languages also, because till now these guidelines we have it online, we have international guidelines also, but now we are also coming up with the IPATH statements and the standard operating practices, what we should do. And we are also trying to put it in different languages so that it is easy for everybody to comprehend and follow them. Can we go to the next slide, please? So when is an adult eligible? So we know that, as I told you, that they should fulfill the DSM-5 criteria. They should not have any psychiatric comorbidity which can interfere with the diagnosis. They should be knowledgeable about it. It should not happen that the patient is not in the best of the mental health to take the decision. And they should be aware of what they are going through. They have to be aware that how this is going to work out. They should not take decision in a hurry, because we have many clients who come to us and want to start hormones immediately and get immediate effects. We should never do that, because it should always be done as per the guidelines, slowly, with monitoring of the side effects, because it can be very, very deleterious for the patient. Can we go ahead? So what are the criteria? As I told you, persistent, well-documented gender dysphoria or incongruence, and capacity to make the decision, consent. Age of the majority for the treatment is 18. We cannot start gender-affirming hormone therapy before the age of 18. We can only start puberty blockers before the age of 18. So we can give puberty blockers to stop the puberty from progressing. And once the patient is beyond the age of 18, they can take a decision to start the therapy if they wish so. But before 18, we cannot give the trans therapy. Like, means if a patient is a trans male and wants to take testosterone, we cannot start. We can only give puberty blockers. That is to stop the periods for the patient we can give. But the patient can be given testosterone only after the age of 18. Similarly, if it's a trans female, we can only give leuprolide to reduce the inherent testosterone levels, but we cannot give estrogens or any estrogen form of therapy before the age of 18. So can we go down, please? So this is some of our, go down, please. So this is some of our center data where we have talked about that they present at a later age to us. Like, this was around few years back, but now, as I was telling, many of the patients or individuals are approaching me at 18. Many parents are approaching me at 15, 16, but at that point of time, we can only give puberty blockers. Still, there is a lot of lack of information. Follow-up is intermittent. Many of them are not educated, and the family support is also very less many times. But the sea change I have seen in the past 7 to 8 years, I have seen that there is a lot of change in the family support system, and a lot of parents are actually supporting, and that is a very good thing I have seen, that because the society has got information about it, and they have understood that this is not something which is not the correct way to go, because if the person is not feeling comfortable with the designated gender, and they want to convert to the opposite gender, this is absolutely as per science, and there is nothing we are going to harm or do anything. So a lot of parents are coming along, and they are actually taking care of their children. So that's a very, very good thing we have seen. Can we go to the next slide, please? So when to start the hormone therapy? First, we have to see what the patient wants. I have some clients who say that I want very mild changes. Some clients who don't want any subtle, they don't want any frank changes, because they say that suppose that there's a trans female and the person says that I don't want my breasts to show up too much. I can just manage with little bit of the tight undergarments, but I don't want it to show too much, and I don't want too many visible changes. So let me be on a small dose of estrogen. And similarly, trans male may say that I need only low dose of testosterone, because I don't want to go ahead with frank changes, and I don't want hairs to come too much, but little bit of hair is fine, or the voice change little bit is okay. So that is what we have to ask, what they want. We can't just start full dose for everybody. Anyways, we start low dose at the baselines and go on monitoring any side effects if it happens, and then increase. But anyways, we can't start full dose immediately, but later also we escalate the dose only with the patient's consent, and they should be knowing what is happening, because I have some clients who are not at all aware, and they said that if I want to convert to trans female, can I have children also? So these type of things, they should be clear, because this is only the phenotypic external appearance we can change. We can't change the internal appearance, though we know that there are options of uterine transplants and all those things coming up, but still that is not something which we are talking at the moment, because it's not available. These are all things which we talk theoretically at the moment. And we have to rule out any other medical problems or any other things, because some patients have diabetes, some have dyslipidemia, some other problems. So that all has to be taken care of. So that also we have to talk about, do all the blood tests for that. Can we go ahead? So initial evaluation, we have to do the detailed personal and family history. We have to see for any other things, any liver dysfunction, any psychiatric problems, any substance abuse, any any HIV or sexually transmitted diseases, what is the fertility desire, what they want, are they sharing needles or they are prone for any infections, any thromboembolic disease, especially for trans females where we are going to give estrogens, any history of diabetes, renal disease, hypertension, all these things have to be talked about. Can we go ahead? And before I proceed, can we go ahead to the next slide? So before I proceed to the next slide, the only important thing is, before we do all these things, we have to be very careful, because as doctors, we also have to be aware that a lot of times there may be some disorders of sexual differentiation, which can mimic gender incongruence. Like they may be having some genetic defect in the enzymes or something, and because of which they might not have been treated, and they might have been androgenized because of high testo, like if you talk about 21 hydroxylase deficiency, CH and all that. So they may, or 5-alpha reductase, where they may not be properly masculinized, or CH, where a trans female may be virilized. So those are the cases where you may erroneously get a diagnosis of gender incongruence. Those are not the gender incongruence. So gender incongruence is if a person is born normal male or female, has a phenotypic characteristic of a male or female with the same karyotype, is not comfortable with the gender but want to convert to the opposite gender. That is gender incongruence. But if they have any of these inborn errors or enzyme defects or problems, that is a separate entity in itself. So DSDs have to be dealt separately. So we better take a consent before starting, because the patient has to be aware of the risks, the psychological and the physical risks. We have to talk about fertility. We have to tell them about sperm banking in case of trans females. We have to talk about ovum banking in case of trans males. So all this should be discussed openly, told to at the outset, at the first visit, so that the patient is well aware of it. Can we go ahead? Next. So when to start, we should have to suppress the natal gender. And as I told you that puberty blockers can be given before the age of 18, but we cannot give gender-affirming therapy before the age of 18. So we have to suppress the natal gender characteristics. So if it is a trans female, we have to give her leuprolide to suppress the testosterone, and we have to give her estrogens to cause the effects of a female or the phenotype of a female. If it's a trans male, we have to suppress the inherent estrogen. Normally we don't need to give leuprolide, but only testosterone will do the job. So once we give testosterone, their estrogen levels also start coming down, and it suppresses. And sometimes we might need to give leuprolide for stopping the menses, or we can give progesterone also to stop the menses. So we suppress the natal gender and give the desired gender therapy. Can we go to the next slide? So we, as I said, so it has to be chosen as per with the patient's discussion, cross-sex hormones, and alongside with the patient being told clearly what we are going to do. Can we go to the next slide, please? So when we do the test for male to female, that means a patient is a male and wants to convert to a female, we have to check for their metabolic profile, glucose values, cholesterol. We also have to check their hormones like prolactin, testosterone, estradiol. We have to check their renal functions. We have to preferably do a BMD for bone health to check if everything is okay. Cardiovascular risk assessment should be done, and hemogram. And also, if you have a patient who's going from male to female, we also should see the liver functions, ask for history of thromboembolic phenomena. So these things are also very important. Can we go to the next slide, please? Karyotype is mandatory as per the guidelines, but sometimes our patients cannot afford, so we don't do. But if you are very sure that the gender assignment is very correct, so we may not do, but as per the guidelines, we are supposed to do. Transfeminine hormone therapy, when we give estrogens, which can be 2 to 6 milligrams per day, mostly. Start off with 1 milligram, go to 2 milligram. It is available as oral, it is available as patches, it is available as injections. Some gels are also available. Most of our clients do well with 6, but we escalate the dose over 6 to 8 months to a year. We can't go with the highest dose on day 1. Some patients may need 8 mg. We have to keep the estradiol levels in the female range of 100 to 200 picograms per ml. Can we go to the next slide, please? So when we are talking about anti-androgens to suppress or reduce the action of the in the testosterone for a trans female, we give spironolactone, which can range from a dose of 100 to 300 milligram per day. And that is why we monitor the potassium. We can also give cyproterone, but cyproterone in this dose is not available in our country, though in Germany and all, they are using a lot of cyproterone. Ours, we have cyproterone, but it is in combination with estrogens and progesterone, in combination with other medications. So we are not using those preparations because so individually we don't have these type of dosages available, but mostly we use spironolactone or we use leuprolide, which is the best. If you have to give the best therapy for reducing the male hormone level, then we can give leuprolide. First, we start off with 3.75 once in a month, and then we go to 11.25 once every 3 months. Can we go to the next slide, please? So what are the time frames of the hormone therapy? If you see, the first 3 months, it actually lowers the libido. In first 6 months, we get breast growth, body shape changes, softer skin, reduction of the testicular volume, less upper body strength and muscle mass. We also know that the muscle mass comes down and the body strength and the hand grip also comes down. And first year, we see slower facial and body hair growth because we are reducing either the level of the testo or the action of testo. Then we see by 2 to 3 years, the maximal breast growth and the body fat redistribution. And that's why sometimes the patients will tell that I haven't got that much of breast growth in 6 months and they want to go for surgeries. That's what we recommend, that you should wait. And we should see for 2 to 3 years, and mostly it will be there, and most of them don't need to go for surgeries. Can we go to the next slide, please? So other procedures, we have to understand that they may go for other dermatological procedures for facial feminizing surgeries. Voice training may be needed. Most of the time, they don't need to go for surgeries for voice, but some of the patients may opt for, but only few doctors are trained to do these surgeries. Cosmetic procedures as by plastic surgeons, fillers and all are being done. Breast augmentation, breast implants, orchidectomy and vaginoplasty is also patient's choice. It's not mandatory. Nothing is mandatory. It is as per what the patient wants, and they discuss with the doctor and we decide. Can we go to the next? So when we talk about the male to female, as I said, that estradiol and testosterone should be in the range for a female. That is estradiol 100 to 200 picograms per mil, and testosterone should be less than 50 nanograms per dl. Can we go to the next? So trans females, when we follow up, we have to follow up for any clots, venous thromboembolism. We have to check their prolactin. We have to do their metabolic screen. We have to check for liver functions, cholesterol, BMD if needed on follow-up after 2 years. We might have to do a cardiovascular assessment, especially I have trans females who are coming to me at a later age of 35 plus, and they have started hormones now. So I have to follow them up for their cardiovascular health. And don't forget prostate cancer, because they are trans females, people tend to forget that they are actually phenotypic, they are females, but genetically they are males. So they need prostate cancer screening. So that's very, very important, which is mostly forgotten. Can you go to the next slide, please? So if you talk about metabolic health, we know that once we start the hormones for them, there's a reduced lean body mass, their fat mass increases, they can get high triglycerides, so we need to monitor. We have to monitor their liver functions, and we also should see that they are not having any addictions. Smoking and all has to be totally a big no. Lifestyle modification is mandatory, physical activity is mandatory. Can we go to next, please? And if you see the cardiovascular outcomes, we have to see for their dyslipidemia. We know that they may be predisposed to oxidative stress, they may have inflammation, so they may be predisposed to vascular disease. So we need to follow them up. We don't have data beyond 10 to 15 years of trans females for cardiovascular health follow-up, so in great numbers. So we have some smaller studies. So we know that after 10 years, the risk may be higher, and we need to definitely follow them up and give them anti-dyslipidemic therapy, or we need to counsel about cessation of smoking, lifestyle. All this is very, very important. Can you go to the next? So we know that when we talk about feminizing, this is our center data where we found that the insulin levels, fasting insulin, and these patients were found to have more insulin resistance. Their body composition did not change significantly at 1 year, because these patients we followed up till 1 year. Now we are following more, but they had some reduction in the LDL that was useful, but there was an increase in the insulin resistance. Can you go to the next slide, please? So bone health is very important, as I said, because you're reducing the testosterone levels, so bone health may suffer. We have to see that they take adequate calcium and vitamin D, and we have to encourage physical activity, and we have to explain that after orchidectomy, they should not stop taking hormones, because if they don't take the hormones, their bones may become very weak. They may have compromise of their cardiovascular health, which can be very, very deleterious. So calcium, vitamin D intake should also be encouraged and should be provided. Can we go to next slide, please? So can we go to the next one? So skeletal health, we know that by the time they start the hormones, sometimes they might have done surgeries very early, and they wouldn't have achieved the peak bone mass, and they might have compromise of their bone health as well. Can we go to the next slide, please? So in our study, our data, we found that females who underwent orchidectomy and they were not taking the hormones properly, they had a lower mean Z-score at the hip and spine because they had stopped hormones for quite some time, and they were not even having testosterone because orchidectomy was done, and they didn't take the estrogens. And even later, when they were taking the estrogens, they still had a lower mean Z-score at the hip and spine, meaning to say that their bones were weak compared to individuals who did not undergo the orchidectomy procedure. Can we go to the next slide, please? So this is one of our other paper where we try to see the muscle strength and body composition, and we did find that the muscle strength reduces with in trans females, and it actually increases in trans males when we give testosterone, as compared to the phenotypic female in as compared to a genetic female in a trans male has a better muscle strength, while a trans female as compared to a genetic male has a poorer muscle strength. So this is what we found in our study as well. Can we go to the next? So if you see, there are different types of studies which are available. I don't know, the slide is not showing up here. So we do see that the bone health has issues, and they have tried to see in transgender youth as well. And they did find that the gender-affirming therapy has a positive impact, but when we are doing it in trans females, there can be some reduction of the bone mineral density. Can we go to the next slide, please? Mental health is another important thing because they need a lot of support. Sometimes they may not be having a good family support. So we should be very careful and we should try to help. And that's what we do at our center, that they need sometimes more of our counseling as well. And we do try to also make them aware of their peer groups who can help them with any of the mental health issues. Can we go to the next slide, please? So for the cancer and the mortality, we need to also follow up. And we need to see that they are screened. And as I told you, trans females also have to be screened for prostate cancers, which we commonly forget. Other cancers, as per the guidelines, we have to see. And when you talk about breast, they have to be followed as per the cis female guidelines. What we follow for breast, we have to do the screening. And neovaginal cancer is also well known. So that is why cancer of the vagina, which is male for the trans females, can also happen, which is called as very, very rare it is, but it can happen. Cancer of the neovagina, so we need to screen for that also. And annual the pap smear, annual pap smear examination is also important. So because these patients may have multiple lifetime sexual partners, so we need to see for any of the other malignancies in the anal area also we have to screen. Because it's a trans female, so we will have to, and they'll have a vagina made, so neovaginal cancers can be one possibility, which is not very common, but we need to screen for that. We should not forget. But as I told, prostate cancers we mostly forget because it's a phenotypic female, so mostly they are not even screened for that. Can we go to the next slide? So as I told, cancer screening of neovagina and prostate is important. Can we go to next? Hyperprolactinemia, as I already told you, that patients who start hormone therapy, female hormone, may have hyperprolactinemia. So we need to monitor, we need to check for the prolactin. As I told you, we check at the baseline. Can we go to next? So now I'll talk a little bit about female to male, that is the trans males, where the patient has been born as a normal phenotypic female with a female gender, but karyotype of a female, but patient is not comfortable and wants to convert to male. And there we give testosterone therapy, which we give as IM injections or gels. And these tests can be also given subcutaneous. We don't have the patches available. We have gels, we have IM injections, we have subcutaneous. So we can give that to give the male hormone levels or the male levels to the female who wants to convert to a male. And we have to keep the serum testosterone in the range of cisgender men. And we are definitely with this, only the menses mostly stop. So we don't need to give any other therapy like leuprolide, but sometimes the menses may not stop and we might need to give leuprolide, or we might need to give them medroxyprogesterone, which can also help in stopping the menses because sometimes they cannot afford leuprolide. Can we go to the, but that is only needed initially. Once their testosterone dose of 200 or 250 plus every 3 to 4 weeks is reached, most of the times, 90% of the patients, the periods will stop. Can we go to the next? So when we talk about the masculinizing effect of testosterone, they'll have more acne. They will develop facial and body hair growth, which will take minimum 6 months to 12 months. So patients sometimes call and say that my growth is not starting, but it'll take time. Fat redistribution happens. Cessation of menses may take up to 6 months to a year also. Clitoral enlargement starts and vaginal atrophy also happens. The deepening of voice happens by 6 to 12 months. That's why we always tell our clients to be careful, because sometimes they don't want the things to show up and they just want to take, but the voice change will happen after 6 to 12 months. Can we go to the next? So monitoring, when we are trying to do in transgenders, we have to keep the target level between 400 to 700 nanograms per DL for testosterone. It has to be measured. If we are giving inanimate, it has to be measured midway between the injection. When we are using undecanoate, then we have to measure just before the next shot. And if the level is less than 400, then we adjust the dosing interval. Transdermal, we should not check the levels at least after a week of daily application and at least after 2 hours after the application. So the monitoring for all the patients, whether it be trans females or trans male, has to be done every 3 to 6 months. Initially, every 3 months for the first year. After that, if everything is stable, you can check every 6 months also. But you need to follow up for metabolic side effects and the hormone levels. You should not stop the follow-up. Can we go to the next slide, please? So this is our center data of female to male, where we tried to see the HbA1c, and we did find that there was a little bit of the increase of the HbA1c with the testosterone therapy, though we did not see any change in the fasting glucose values and the other lipid parameters, except for the HDL, where we found a bit of reduction with the follow-up. Can we go to the next slide, please? And we also tell them not to have smoking and again addictions or anything, because that can be very, very harmful with this. And we also have to monitor hemoglobin and PCV. So when we give testosterone therapy in trans males, so it's the patients may get high hemoglobin, high PCV, polycythemia can happen. So hemoglobin and PCV management monitoring is very, very important. Can we go to the next slide, please? So we know that when we are giving the testosterone, there can be amenorrhea over a period of time. So that's why patients are told about fertility option. If they want to go for it, they have to do it in the beginning itself before they start the hormones. Later on, after starting the hormones, if they want to still go for fertility options and they wouldn't have decided about it before, then we tell them to stop the hormone therapy for 3 months and then do it, because that's how we can do both in trans females as well as trans males. Trans females sperm banking can be done at the beginning, or if they decide later before orchidectomy, they can stop the hormones for 3 to 4 months and do it. In trans males, we do the ovum banking best at the beginning. If the patient has not yet decided, not confirming, later on they take a call. So before they do the hysterectomy and the oophorectomy, they can stop the hormones for 3 to 6 months and we can try to retrieve the ovum. Can we go to the next slide, please? So we need to monitor, as I told you, for hemoglobin and PCV and for liver functions, because testosterone may have a bad effect on the liver. If we find derangement of liver functions, we can give transdermal testosterone preparations as well. And definitely metabolic parameters like lipid profile, glucose values, and thyroid also over a period of time. Can we go to next slide, please? So basically what we have understood is diagnosis is most important, because I have many patients who are disorders of sexual differentiation but erroneously diagnosed as gender incongruence. That's why a consultation with the endocrinologist before starting hormones is important. And the patients many times may start, but they may not continue to take the treatment. So that is why we have to explain what is the rationale and how we are going to do. They also have to understand that many times trans females, I have seen that after orchidectomy, they don't come for hormone therapy, and then their bone health, metabolic health, cardiovascular health goes for a toss. And that is very, very important that they need to follow up. Regular follow-up is important, and we have to see for side effects also. As I told you, mainly metabolic side effects and monitoring the hormone levels. And for testosterone therapy, hemoglobin, PCV, SGP, TOT. With trans females on estrogens, we have to see for glucose, lipids, triglycerides, also prolactin levels, as I told you. If the side effects are happening, either stop temporarily or de-escalate or change the method of administration, mode of administration. Like suppose a patient is getting side effects with injections of testosterone, we can change to transdermal because gels, because that can cause less liver side effects. It bypasses liver. Similarly, if estrogens are causing side effect on the liver, we can shift to estrogen patches or estrogen gels. Fertility preservation options are very important. I have clients who have come to me who never been told about fertility, and they would have done the orchidectomy or the hysterectomy, and then they are told that this is possible. So this is not, should not be done. Cancer screening, we should not forget, because they convert to the opposite gender. So many a times the inherent cancers are not screened for. So that's important. And many of the trans males would not have gone for hysterectomy or oophorectomy. So they need to be followed up for uterine health and ovarian health. Ultrasounds once in a year would be good to do. That's also very important. Next slide, please. So these are a few of my patients who are running the NGOs in Karnataka and Akai, and a lot of my other trans patients who help the other trans patients also and create awareness, because these are the people who are creating awareness that how we can help the community the best. So whenever we have patients who need some help, because these are the people who come forward to help them, and I think they provide a good forum, or they are the ones who actually tell that what experiences they have. And I know that one of the speakers today, next speaker today, is also talking about her experience. So that's very important, because we sometimes as doctors or as clinicians may not actually understand the ground level problems, which they help us to understand better and do better management of our clients as well. Thank you.
Thank you so much for your presentation, ma'am. We have a short question and answer session. Can we proceed with that?
Please, please, please.
Yes, ma'am. In your presentation, you had mentioned that you were part of framing some of the diagnostic criteria for trans people, which is very impressive. So we have a question pertaining to that. How do we train general practitioners or non-specialists to apply these criteria appropriately and affirmatively?
I think it is very, very difficult, because a lot of times many of the doctors don't want to learn also, because I myself have organized many CMEs to train. The best way out is to teach, and there's no other way. So I have tried to do many CMEs, but many of the doctors are not interested, because they think that this may carry a lot of legal implications and all. So there are a group of doctors who are interested, who keep on calling me. So what they do is, if they think that a client has gender incongruence, patient needs help, they would call me and take my opinion, or they'll call some of the other doctors who are working with gender incongruence, and they will take their opinion, because they may not be able to decide. But these criteria can only be told to people through CMEs, through lectures, through talks. That is how, and people have to read, because now, till when we were MBBS students, actually we didn't have any much exposure to transgender treatment or guidelines, because there was nothing such existing majorly at that time. But now, because the curriculum has also been changed, and there is definite talk on that, and I have my students who are actually well versed. So I think the next generation of doctors like you who are coming up definitely have good information. But yes, we understand that the previous generation might not had direct information about it or direct association, but from different CMEs and other things they can learn. That is how best we can teach them. And we are a set of doctors in India who deal with gender incongruence. So many a times the other doctors or the physicians, if they have doubts, they call one of us in their city and they take help. So we are ready to do that as well. And we do regular CMEs actually on this. And in all our conferences, we actually keep a topic on this, or a seminar and one session on this to teach the people. That is what we are doing actually.
Yes, ma'am. Thank you so much. Another question is, what are the medico-legal implications of denying gender-affirming reproductive care, and how can young clinicians protect themselves and advocate for their patients?
So we cannot deny therapy. We can only say that we may not be able to offer and refer. because there may be a group of doctors who may not be well versed with how to go about it. Because like we talked about diagnosis, now suppose a doctor is not able to decide whether he or she is actually dealing with gender incongruence or not, that doctor should not treat, because that doctor may not take the right decision. So such cases, it is good to refer. So the medical legal implications is we cannot deny, we have to give the care. If you are unable to give the care because of the lack of knowledge, then it is a good idea to refer the patient. That is what we advocate. So denial cannot be done. No therapy can be denied for any disease. You can't deny a patient to be treated for diabetes. You can't deny a patient to be treated for thyroid. Similarly, you cannot deny anybody. So denial cannot be done. But what I'm trying to say is, in case you are not knowing that what is the correct diagnosis, or am I dealing with it? Because I had some doctors, general physicians who were confused, and they were actually, as I told you, some disorders of sexual differentiation. They were thinking that they are gender incongruous, and they were not gender incongruous. So that is why, that is not denial of therapy. That is, they were not aware what exactly is the thing. So they have to refer to the specialist. So this is not denial. This is now they are not able to make the correct diagnosis, so they can refer. But yes, we cannot deny the therapy. That is not allowed for any reason. So that is a similar thing for gender incongruence.
And we have a very interesting question here. It is how many genders actually exist biologically? Can we define that?
See, there are lots of genders which can be, we identify, as I told you in the beginning, there are a lot of things which we talk about: gender identification, gender identity, the societal role. So it is not one definition. It is not like I can say there are 10 genders which exist in the society. It is not like that. There are different terminologies, like I told you in the beginning. So it's an identity or the gender expression. So each one has a different thing. So there may be people who may identify as male, some people may identify as female, some patients may say, no, I am fluid. Some patients may say, no, I identify as both. So that is a patient's perception. So it is, if you talk about science, we say either it is male or female, or if it is by some genetic issues or something, hermaphrodite, or that is a different thing, that's a DSD which comes into place, then that is how we talk about. But these are our scientific terminologies. But when you talk about the expression identity, there are all these types of different types which we can talk about, and there's a huge seminar in itself where we keep on talking about what is fluid, how much some people are gender fluid, some people think themselves binary. So all these things we need to talk about. So that is, it's very difficult to define in 4 lines and say that, yeah, these genders. It's not so easy to classify. It has to be as per the expression or the identity or societal terms. So in each way, we have different ways of expressing it.
Thank you so much for your esteemed expertise, ma'am. It was of great value to us.
Fine.
Dr. Kalra, thank you so much for being here with us today. Honestly, the way you explained everything, it was amazing and helped us understand gender affirming care to a whole new level. We're really super grateful to you to take this time out of your very busy schedule to be here and share your perspective with us. Thank you so much again.
Thank you. Thank you.
So up next, we have a very, very special guest. Her name is Swara. She's a very fierce advocate and an inspiring voice from the trans community. And today she'll be sharing her personal journey on hormone therapy and what gender-affirming care has meant to her. We're so grateful to have her here with us. Swara, over to you.
Hello, thank you so much, team, for inviting me to share my HRT experience. And I'm honored to hear Dr. Pramila. Today only मेरी आज टीम से बात हो रही थी because ये मैं थोड़ा प्रिपरेशन कर रही थी इसका कि तो मैंने ट्रांसमेन 2-4 ट्रांसमेन मेरे जो भाई वगैरह है उनको मैंने कॉल करी थी तो they told me about Dr. Pramila ma'am. तो I'm so blessed कि उनको मैं मिल पाई through this webinar. My name is Swara Thapa. My pronouns are she and her. I run CBO, Swaratma Foundation. This is Translate CBO. Like we are working on education, empowerment, and employment for the transgender and queer persons in Delhi. From last 7 years, I'm working in NGO field, and this is my new organization. From last 3 years, we are working on this on the ground, on the root level, to empowerment the trans community and the queer community, basically. exactly like almost 11, it has been 11 year like taking हार्मोन्स. मैंने तो अभी तो छोड़ दिया है. 11 साल पहले मैंने पहली बार हार्मोन्स ली थी, एचआरटी जो हार्मोन रिप्लेसमेंट थेरापी है, तब मैंने स्टार्ट करी थी व्हेन आई वाज 22, ऑलमोस्ट 22, 21 क्रॉस करके 22. तो तब तो लाइक दैट टाइम वाज सो इतना इंडिया में इतना वो नहीं था इजीली अवेलेबल हार्मोन्स वगैरह, तो बहुत कॉस्टली पड़ता था, लोगों को पता नहीं था कि ये चीजें क्या होती है. तो बहुत थोड़ा मुश्किल होता था तब की टाइम में. अभी तो बहुत इजी है. देयर आर लॉट्स ऑफ सीवीओज, एनजीओज, ऑर्गेनाइजेशन, ट्रस्ट, लाइक दे प्रोवाइड hormones knowledge and all free of cost, like they do have contacts of doctors. तो अभी तो बहुत इजी है. तब हमें जब मैंने स्टार्ट करी थी 10-11 साल पहले, तो बहुत एकदम हम सोच में पड़ते थे कि ये चीज क्या है. लाइक being born on male body and I'm changing to my I'm thinking to change my body into a female. तो एट दैट टाइम सोचना पड़ता था कि क्या ये चीजें पॉसिबल है कि नहीं है, कैसा है, क्या होगा, परिवार वाले क्या बोलेंगे. तो इस कारण मैं एजुकेशन भी मैं कंप्लीट नहीं कर पाई व्हेन आई लेफ्ट द एजुकेशन. तो तब तो बहुत 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 मुश्किल था. अब तो इट इज सो इजी, थोड़ा बहुत इजी है. अब लोग जैसे हो कि आके हमसे पूछते बच्चे कि ऐसे कौन सा एज है जो स्टार्ट करना चाहिए. ऐसे तो हम 18 प्लस को हम रिकमेंड करते कि यू शुड हैव लाइक आप वो कर सकते हो, आप ले सकते हो, आप डॉक्टर के पास मिल लो. जो सीबीओ के साथ कनेक्टेड होते हैं उन डॉक्टर्स के हम नंबर्स वगैरह हम शेयर कर देते हैं. एंड लाइक मुझे रियलाइज है जब मैंने पहले हफ्ते मैंने जब ये एचआरटी जो हार्मोन्स होती है जो मैंने स्टार्ट करी थी, दैट टाइम प्रोजिनोवा ये वगैरह थी. तो 2-4 मेडिसिन थी, 3 मेडिसिन आई वाज टेकिंग एट दैट टाइम. तो 1-2 हफ्ते के बाद में मुझे बहुत मेरे बॉडी में या मेरे इमोशनल मेंटल हेल्थ में बहुत फर्क पड़ी थी. लाइक आई यूज्ड टू क्राई अ लॉट थिंकिंग कि व्हाई आई लेफ्ट माय फैमिलीज एंड लाइक व्हाई पीपल यूज्ड टू जज मी. तो रात को मैं बहुत रोआ करती थी तब कि ऐसे मेरे साथ ये क्या हो गया. लाइक उससे पहले मैं इवेंट मैनेजमेंट में थी. तो मैंने यंग एज से ही स्टार्ट करा अपने अपने आप को एज एन सेल्फ मेड पर्सन बनाने के लिए. मैंने यंग एज में ही मैंने काम स्टार्ट करी थी. तो तब मैं थोड़ा ठीक था मेरा. तो मैं सोचती थी मैंने ये गलत तो नहीं करा, ये तो नहीं करा. फिर देन आई केम टू मीट मेनी ऑफ यू नोज रुद्रानी छेत्री. हैव यू हर्ड अबाउट हर और नॉट? तो आई यूज्ड टू कॉल हर ममा नाउ. तो मैंने मम्मा से बात करी, रुद्रानी छेत्री मैम से, जो दिल्ली में उनकी फर्स्ट सीबीओ मित्रा ट्रस्ट के रूप में उन्होंने काम करे थे. तो मैंने उनसे कंसल्ट करी कि ऐसे ऐसे चीजें होती है मुझे. एंड बाय लकीली शी इज आल्सो फ्रॉम दार्जिलिंग एंड आई एम आल्सो फ्रॉम दार्जिलिंग. वी शेयर कॉमन लैंग्वेज, नेपाली लैंग्वेज. तो बहुत इजी हुआ उनसे कनेक्ट होने. देन जब मुझे ऐसे अलोन फील करता था तो वो बोलते थे बेटा आना मेरे पास, तो तुम यहीं रुक जाना, 1-1.5 हफ्ते रुक जाना. जो भी परेशानी हो तुम मुझे बताना, तो सो दैट आई कैन हेल्प यू. अगर मुझे मेरा ऐसे कुछ है तो मैं हेल्प कर सकूँ. तो उनसे मैंने बहुत चीजें की नॉलेज लिया. उन्होंने बहुत चीजें बताई. तो थोड़ा जब फैमिली की आपको सपोर्ट नहीं होता ना, तो जब एक परिवार इधर कम्युनिटी में मिल जाता, अपने जैसे परिवार मिल जाता है, तो दैट टाइम बहुत हेल्प हो जाती है. तो सम टाइम मुझे ऐसे भी मेरे दिमाग में आता था कि सुसाइड कर लूँ, ये बहुत चीजें गलत हो रहा है मेरे साथ, लोनलीनेस होता था. तो मैंने सब उनको बताया. तो उन्होंने सी गाइडेड मी very well. She took me in her house. Then she advised me to not to smoke, not to have alcohol and all. तो मैंने उनकी बात मानी थोड़ा सा. तो मुझे थोड़ा सा फील होने लग गया, हाँ दिस इज द थिंग्स कि ठीक है. अब जब अपने आप को मैं 11-12 साल पहले देखती हूँ या आज देखती हूँ, तो मैं आज लोगों को बताती हूँ कि आपको ऐसे करना चाहिए, वो तो हार्मोन्स वगैरह के बारे में ये लेना चाहिए, या आपको डॉक्टर के साथ कंसल्ट करके हार्मोन्स लेना चाहिए बेसिकली. तो मुझे बहुत प्राउड फील होता है कि एट दैट टाइम अगर मुझे राइट गाइडेंस नहीं मिली होती तो शायद 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 आई वाज नॉट, मैं अभी यहाँ होती नहीं होती, वो भी नहीं पता थे. तो क्योंकि बहुत वो हार्मोन्स के कारण बहुत अलोननेस फील होता था, बहुत एंगर इश्यूज भी आता था छोटी छोटी बातों में कोई चिढ़ा दे तो एकदम उसको एकदम मैं सोचती थी कि इसने मुझे ऐसे क्यों बोल दिया, तो एकदम एंगर इश्यूज वगैरह भी आते थे, समटाइम्स सुसाइडियल थॉट्स भी होते थे। बहुत मैंने स्टोरीज भी सुनी इन द साउथर्न पार्ट, मेनी डू सुसाइड बिकॉज ऑफ दिस। एक करेक्ट एचआरटी जो होता है ये जो अच्छे से वो लोग जब प्लान नहीं करते तो फिर ये सारी चीजें आते हैं। और कम्युनिटी में एक चीज की कमी है कि कम्युनिटी में कम्युनिटी एक दूसरे के सुनते हैं। जैसे मान लीजिए मैंने अगर डॉक्टर से कंसल्ट करके मैं कुछ एचआरटी में कुछ मेडिसिन वगैरह खा रही हूँ, तो कम्युनिटी मुझसे पूछेगी, डॉक्टर से नहीं पूछेगी आप क्या खा रहे हो, आपके बाल इतने लंबे हो गए, फेशियल हेयर्स वगैरह आपके चले गए, आपकी ये हो गया, आपकी बॉडी वगैरह थोड़ा वो हो गया, साइन हो गया, व्हाइटपन आ गया बॉडी में, तो आपने क्या करा, आपने क्या खाया। अब इजीली कोई पूछता है तो कोई भी बता देता है, मैं भी बता देती थी कि मैंने प्रोजिनोवा खाई, जिनेट खाई, ये सारी चीजें मेडिसिन के नाम। तो कम्युनिटी लैक ऑफ इन्फॉर्मेशन मैं उसको बोलती हूँ, या लैक ऑफ नॉलेज, कि वो लोग कंसल्ट ना करके वही चीज फिर छुप छुप के खाना स्टार्ट कर देते। तो मैंने कितने को मैं समझाती भी हूँ, वो क्योंकि मेडिकल वगैरह में इजीली मिल जाती है ये मेडिसिन वगैरह, एक बार पता होने, नाम पता होने के बावजूद। तो फिर कम्युनिटी और उसके कारण भी बहुत चीजें होती है, जैसे डिप्रेशन, ये सारी चीजें। तो वो चीज ये नहीं समझते कम्युनिटी एकदम से, अच्छा ये इन्होंने, क्योंकि डॉक्टर्स के लिए फीस लगती है ऑफ कोर्स। कम्युनिटी ये सिचुएशन में नहीं है कि वो बहुत सारे कम्युनिटी, ऑलमोस्ट 90% कम्युनिटी, एलजीबीटी कम्युनिटी लैक ऑफ फंड्स होते हैं, वो लोग प्रॉपर डॉक्टर के यहाँ जा नहीं पाते, उनको शर्म आती है डॉक्टर से मैं क्या बोलूंगी, डॉक्टर पूछेंगे तो नहीं मुझे कि क्यों तुम लड़की बन रही हो या क्यों तुम लड़का बन रहे हो, तुम ठीक ही तो हो, अच्छे ही तो हो। तो बहुत चीजें वो ये सारी चीज से, डर से, और पेरेंट्स ना जान ले या पेरेंट्स को पता ना चल जाए, डॉक्टर पेरेंट्स को कॉल ना कर दे, ये सारे अ, चीजों से वो लोग डॉक्टर के यहाँ रीच नहीं होते। डायरेक्टली पूछ लेते एक दूसरे को, जैसे मैंने एक को बता दी, एक ने दूसरे को बता दी, दूसरे ने तीसरे को बता दी, तो ऐसे ऐसे प्रोसेस करके चलते हैं। अब वो तो हार्मोन से उसके इफेक्ट तो होना ही है, किसी को अच्छा इफेक्ट होता है, किसी को साइड इफेक्ट ज्यादा दिखा देता है, लेकिन हमें करेक्टली इन्फॉर्मेशन के साथ ही एचआरटी खाना चाहिए। ये तो मेरी शॉर्ट एचआरटी की जर्नी थी, बट बिकॉज ऑफ सम हेल्प फ्रॉम रुदानी ममा, तो uh, मेरा तो बहुत अच्छा गया तो टाइम, लेकिन मुझे 2 हफ्ता बहुत बहुत दिक्कत हुई थी। मतलब 2 हफ्ते में मुझे पता चल गया था कि मैं बहुत अकेली हूँ, कोई नहीं है, दैट माय पेरेंट्स डजंट लव मी। तो मुझे ये सारा थॉट्स मुझे बहुत आती थी, सुसाइडियल थॉट्स वगैरह, कि मैं क्या करूँ क्या ना करूँ, कैसे पढ़ूंगी आगे, क्या करूंगी जिंदगी में, एजुकेशन भी छोड़ दी थी। तो मुझे बहुत चीजें, ये सारी चीजें बिकॉज ऑफ एचआरटी मुझे होती थी। तो आज मुझे ये शेयर करने का मौका मिला, मुझे अच्छा लगा बहुत। ये बहुत पुरानी बात है, पुरानी क्या है, 10-11 साल हो गया, बट अच्छा लगा कि लोग अभी भी सुन के तो अब लोग सुन के भी लोग ले रहे, तभी भी समहाउ हम उनको बोलते हैं कि आप डॉक्टर के पास कंसल्ट करिए एक बार, कि हर एक का बॉडी एक जैसा नहीं होता, हर एक का बॉडी डिफरेंट होता है। तो कैसे किसी के बॉडी में इफेक्ट भी कर सकता है, किसी के बॉडी में बहुत अच्छा इफेक्ट भी कर सकता है, किसी की बॉडी में नेगेटिव इफेक्ट भी कर सकता है, ये एचआरटी जो मेडिसिन वगैरह होती है। तो उसके लिए हम उन लोगों को गाइडेंस करते हैं। अभी भी जब अब एनजीओ वगैरह में आते हैं तो कोई पूछता है, तो मुझसे कोई पूछता है, तो मैं पहले तो बताती थी ये मेडिसिन लेती हूँ, अब मैं बताती नहीं हूँ। मैं बोलती हूँ कि आप डॉक्टर के साथ कंसल्ट करो, ये ऐसा ऐसा मेडिसिन है, ये है बोल के हम फिर डॉक्टर को रिफर कर देते हैं आगे। तो डॉक्टर ही फिर एचआरटी के बारे में बहुत अच्छे से वो लोग बता पाएंगे। और अबाउट लाइक हेल्थ 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 की बातें हो रही है, तो हेल्थ तो बेसिक राइट्स है, बेसिक फंडामेंटल राइट्स है एक ह्यूमन बीइंग होने के नाते। तो बहुत ये हेल्थ के भी पॉलिसीज वगैरह नहीं है रिगार्डिंग द ट्रांस सेक्टर में। और साउथर्न पार्ट में तो थोड़ा बेटर है। मैं कर्नाटका, इधर चेन्नई वगैरह में सेमिनार वगैरह में मैं अटेंड करती हूँ, तो बहुत अच्छा लगता है वहाँ की सरकार वगैरह सोच रहे। बट दिल्ली ऑन द नॉर्थर्न पार्ट, तो ये सारी चीज पॉलिसी वगैरह नहीं है, जहाँ पे एक बेसिक फंडामेंटल राइट्स जैसे हेल्थ है। एचआरटी की ही बात नहीं है, बस ये तो एचआरटी का बात आ गए, तो वी आर डिस्कसिंग ऑन एचआरटी। तो लेकिन अपार्ट फ्रॉम एचआरटी देयर आर लॉट्स ऑफ हेल्थ इश्यूज। कितने ट्रांसजेंडर है जिनको यही नहीं पता कि कितने को कैंसर है, कितने को अस्थमा की दिक्कत है, या किसी को किसी भी चीज की दिक्कत है। क्योंकि जो बेसिक फंडामेंटल राइट्स है, जो हेल्थ हेल्थ राइट टू हेल्थ है, वो भी कम्युनिटी को नसीब नहीं होता। ऑन मैं दिल्ली में रहती हूँ। दिल्ली में आपने सुना होगा मोहल्ला क्लिनिक नाम का हर एक मोहल्ला में एक क्लिनिक चलता है। कितने मोहल्ला क्लिनिक में हमें कितने बार लड़ने के लिए जाना पड़ता है कि वहां पे मतलब हमारे लिए पैरासीटामोल भी अवेलेबल नहीं होता। बहुत सारे ऐसे गवर्नमेंट हॉस्पिटल में जहाँ पे ट्रांसजेंडर अगर कोई बीमार जा रहा है तो वहाँ की स्टाफ इतना सेंसिटाइज नहीं होता। वो लोग अच्छे से उन लोगों को मतलब भरना नहीं देते। अगर किसी की आवाज लाउड है, किसी ने ताली तमंच बजाए, किसी ने धमकी दी, किसी ने वो कर दिया तो उनकी होना है। लेकिन जो सॉफ्ट होते हैं, जो मतलब एज एन ट्रांस अपने आप को मतलब एज एन ट्रांसजेंडर बॉडी में भी अपने आप को फीमेल मेल की तरह रखना चाहते हैं, वो लोग अपना ये चीजें नहीं कर पाते, हल्ला हुल्ली करना, ये सारी चीजें नहीं करना। तो वहाँ पे कम्युनिटी के मेंबर बेसिक फंडामेंटल जो ये हेल्थ राइट टू हेल्थ है उससे भी वंचित होना पड़ता है। मोहल्ला क्लिनिक के बहुत सारे केसेस हमने सॉल्व करे, पीछे सरकार के साथ हमने मिलके बहुत सारे केसेस में हमने ये देखा कि कम्युनिटी के मेंबर जब जाते हैं तो डॉक्टर बोल देते हमारे पास मेडिसिन ही नहीं है उस चीज का। और ये सारी चीज तो अब 2-4 ऑर्गेनाइजेशंस मिलके दिल्ली में रन करते हैं। HRT के इंफॉर्मेशन वगैरह फ्री ऑफ कॉस्ट करते हैं। देयर आर लाइक 2-3 डॉक्टर्स फ्रॉम द कम्युनिटी। मुझे एग्जैक्ट डॉक्टर अनमोल, डॉक्टर सेक्स, they are doing very good on the field of this health and all। तो अभी वो लोग कुछ ना कुछ ये ऑर्गेनाइजेशंस वगैरह में रखते हैं, तो अच्छा लगता है। फिर और ऐसे ही बहुत सारे हेल्थ का कार्यक्रम, मेंटल हेल्थ संबंधी कार्यक्रम, ट्रांसमेन, ट्रांस वुमेन या इंटरसेक्स जैसे ट्रांसजेंडर की कैटेगरी है ये, तो इन चीजों में होना चाहिए, हमें अवेयर कराना चाहिए। HRT, सर्जरीज एंड there are lots of health based information जो कम्युनिटी पे पहुंचता ही नहीं है अच्छे से। तो ये सारे चीज अवेलेबल हमें कराना चाहिए। बीइंग लाइक ये शायद ये आप लोग मेडिकल स्टूडेंट हो, तो मैं ये आशा करती हूँ आप लोगों से कि आप लोग ये जो राइट टू हेल्थ जो एक बेसिक फंडामेंटल है ये हर चीज को मिले, तो आप लोग इसके लिए भी काम करो। और ट्रांसजेंडर के तो बेसिकली ट्रांसजेंडर या क्वेयर लाइक LGBT कम्युनिटी के तो बेसिक हमें तो ये होना ही चाहिए, बिकॉज लाइक वी आर वेरी फार फ्रॉम आवर पेरेंट्स, वी आर वेरी फार फ्रॉम एजुकेशन, वी आर वेरी फार फ्रॉम द बेसिक नीड्स ऑल्सो। कितने के पास हाउसिंग नहीं है, कितने के पास अच्छा खाना नहीं है, कितने सेक्स वर्कर है, कितने वो करते हैं। बस हमारे यहाँ पे आती है तो कोई चीजें हेल्थ मीन्स सेक्स, हेल्थ मीन HIV, सेक्स जो सेक्स वर्कर के रिलेटेड है, उतना ही कार्यक्रम में हम बंद कर देते हैं कि हाँ किसी HIV नापना है, TIA टारगेट पूरा करना है, कोई किसी CBO का ये है कि आपको जांचना है, तो ओनली हेल्थ के इश्यू में इतना ही चीजें रह जाती है। तो लोग फिर आगे उसके आगे बढ़ ही नहीं पाते। कितने ट्रांस को कैंसर है, नोबडी कैन लाइक देयर इज नो एनी डाटा अवेलेबल ऑन एनी ऑफिशियल साइट्स। कहीं पे भी किसी साइट्स में ये नहीं है कि नंबर ऑफ कैंसर पेशेंट ट्रांस में कितने हैं, नंबर ऑफ लाइक ऐसे बीमारी जो बहुत बीमारी होते हैं। अब होल कोरोना गया बीच में, इतने सारे कम्युनिटी के मेंबर अफेक्टेड हुए, कितने सारे मरे, लेकिन आज भी एक डाटा नहीं है। हमारे साथ हमारे एनजीओ में कितने आते थे, कितने की डेथ हुई या कितने को मेडिसिन नहीं मिला, कितने कोरोना इन्फेक्टेड हुए थे, वो डाटा सरकार रखती ही नहीं है। क्योंकि ट्रांसफर सरकार यही सोचती है कि दे आर वेरी लेस इन नंबर इन टर्म्स ऑफ वोट एंड ऑल, तो पार्टीज वगैरह ध्यान नहीं देती। जब किसी पार्टी के साथ नहीं होता है तो लाइक अ कंट्री लाइक इंडिया में इतना फिर आपका वो नहीं हो पाता कि आपका समस्या सुने जाती है, वहां पे नहीं सुनी जाती। तो आई वुड रिक्वेस्ट यू ऑल, जब आप लोग स्टूडेंट हो, आप लोग पढ़ रहे हो बहुत अच्छे से, तो आप लोग इस विषय में आप लोग काम करो। वी आर रेडी। हम स्वरात्मा फाउंडेशन एंड देयर आर 3-4 मोर ऑर्गेनाइजेशन विद मी हु वी वर्क टुगेदरली, तो हम आपके साथ देने के लिए हमेशा रेडी है। लेट्स वर्क ऑन दिस ट्रांसजेंडर हेल्थ एंड ट्रांसजेंडर हेल्थ राइट्स। तो ये बहुत मतलब अभी के बहुत वाइटल इश्यूज है हेल्थ, तो ये चीजों में काम होना चाहिए। एंड थोड़ा टाइम लंबा भी हो गया है। थैंक यू सो मच टीम, दिया मैम फॉर द इनविटेशन, for like मुझे बोलने का मौका देने के लिए. Apart from that, like I want to invite you all who are interested to do intern and learn more about transgender health. जो भी सीखना चाहते हो, जो भी वो करना चाहते हो, तो there are lots of transgender individual who visit daily to our CBO. बहुत सारे ऐसा है क्योंकि हमारे ऑर्गेनाइजेशन एक अन्नपूर्णा करके कार्यक्रम चलाते हैं हम, जिसमें हम 2 टाइम का फ्री का खाना कोई भी अगर कॉल करके आता है तो वी प्रोवाइड देम फूड्स फॉर फ्री, और हम अपने एनजीओ में रख के हम उनको खाना खिलाते हैं. तो ऑलमोस्ट 7-8 लोग डेली आते हैं इस दिल्ली के, जहाँ पे हमारे पास में. तो वो लोग आते हैं, हमें बहुत खुशी मिलती है कि उन लोगों के साथ हम बैठ के खाते हैं, आराम से एक साथ बनाते हैं. तो आप लोग भी आ सकते हो कभी भी. और वो लोग अपने तो पर्सनली मेरे से ज्यादा each and individual trans person can share their journey regarding the health or health problems. Thank you.
आप यहाँ आने के लिए बहुत बहुत धन्यवाद. हमारे लिए बहुत जानकारीपूर्ण था. we have a small question for you.
Okay.
यहाँ हम सब फ्यूचर डॉक्टर्स और हेल्थ केयर वर्कर्स बनने वाले हैं. तो आपके साइड से व्हाट इज वन थिंग दैट यू विश, जब एवरी टाइम आप डॉक्टर के पास जाते हो, वन थिंग दैट वी कैन डू that will make you feel very comfortable?
अगर मैं डॉक्टर के पास जाती हूँ तो जैसे मतलब मेरे तो बेसिकली अगर मैं किसी हॉस्पिटल में जाती हूँ या डॉक्टर के पास में जाती हूँ तो हमारे लिए एक सेपरेट लाइन और सेपरेट वॉशरूम होना चाहिए. ये टॉपिक में हम बहुत लड़ते हैं. जैसे मान लो कहीं लड़की खड़ा है, कहीं लड़का खड़ा है, तो मेल एंड फीमेल का लाइन तो होता ही हर हॉस्पिटल में. तो वो चीज हमारे लिए नहीं होता. और each and every in emergency ward there should be a reservation, there should be a bed for transgender. क्योंकि हम देखते हैं हमें लड़ना पड़ता है, क्योंकि सरकारी हॉस्पिटल वगैरह में जब जाते हैं हम किसी को, ज्यादातर तो हमारे कम्युनिटी को ये HIV की ही दिक्कत होती है. बिकॉज ऑफ HIV देयर आर लॉट्स ऑफ और जो डिजीज होती है वो अटैक करते हैं. जब हम उनके ट्रीटमेंट के लिए जाते हैं ना, तो वहाँ पे मतलब हमारे लिए कुछ भी नहीं होता, बस कि तो कोई हल्ला वल्ला करे तो उनको मिल जाएगी, चलो चलो छोड़ दिया. डर के कारण, हम डर के कारण नहीं जाना चाहते, हम सम्मान के साथ जाना चाहते. जहाँ पे भी हो तो हम सम्मान के साथ जाना चाहते, कहीं डर त्रास नहीं, ये लोग बददुआ देंगे, ये लोग ऐसे कर देंगे. तो दीज आर ओनली द नेगेटिव थिंग्स. ये कलयुग है, ये राम राज्य की टाइम चल रहा है, राम जी का टाइम चल रहा है. तो हम बहुत सम्मानजनक हम जाना चाहते हैं हर जगह, चाहे हॉस्पिटल हो, चाहे मंदिर हो, चाहे स्कूल हो, एनीवेयर हम बहुत सम्मान के साथ जाना चाहते हैं. तो वो सम्मान आगे वाले भी हमारे साथ क्रिएट करे. हमारे प्रॉपर जैसे मेल फीमेल के साथ रखा गया है, तो हमारे साथ भी, हमारे लिए भी वो चीजें होनी चाहिए. जैसे हॉस्पिटल्स वगैरह जाते हैं तो टॉयलेट्स वगैरह होने चाहिए. एटलीस्ट एक हॉस्पिटल में एक टॉयलेट तो ट्रांसजेंडर के लिए होनी चाहिए. ये मेरा विश है. और आप सबको ढेर सारी शुभकामना. आप लोग डॉक्टर बनो, बहुत अच्छे डॉक्टर बनो, हर जेंडर की सम्मान करो. मेरी विश भी और मेरी दुआ भी यही है सबके लिए.
Thank you so much.
Thank you. Namaste. Should I exist? And thank you so much, Pramila ma'am. It is very I feel so blessed to meet you. मैं तो आज पहली बार आपको देख रही हूँ. मैंने सुबह से बहुत सुना आपके बारे में. 2-4 ट्रांसजेंडर मेरे भाई है जिनको मैं राखी टाई अप करती हूँ, मेरे राखी ब्रदर्स है. तो वो लोग बोल रहे थे पहले ही देयर इज प्रमिला मैम ऑन बेंगलोर में भी, हाँ बेंगलोर या कर्नाटका ऐसे बोल रहे थे. लेकिन मैम ऑनलाइन सेशन ही लेती है. शी इज द बेस्ट डॉक्टर. तो अभी मुझे दिया ने ये मैसेज भेजा लाइक यू आर विद दिस डॉक्टर Pramila. So I feel so blessed. We did connected. I'll take your contact number and we'll talk more on these things.
Definitely. Nice meeting you too. Nice to hear your experience also.
Thank you.
Very
so
nice.
much.
Very nice. Yeah.
Thank you so much.
So, thank you so much to the amazing speakers today, Swara and Dr. Pramila Kalra. Thank you so much. And thank you to everyone who showed up today. Whether you came as a student or an ally or someone exploring their journey, we're so glad you were here. These conversations might feel extremely rare in this medical space, but they shouldn't be, and we're here to change that. We'll see you for our second Transform session, that is on the 28th from 7 to 8 about gender reconstruction surgery. And if you're not already a SIMSOG member and you all want to see such events, please sign up. It's free. Thank you so much.
Now, if the feedback form has been, the link has been put up on the chat for everyone to take up. Please do ensure that you fill up the feedback form, as it is imperative for certification post the series. Thank you.